Hello everyone. Welcome to SPPH 538 Application of Ethical Theories in the Practice of Public Health. I'm Daniel Steele, your instructor, and I'm coming to you from the traditional, ancestral, and unceded territory of the Musqueam people. In this lecture, I'm going to talk to you about the first reading from the first week of the semester in this class. And that reading is by Childress and colleagues, and its title is Public Health Ethics Mapping the Terrain. So let's move along with that. So one of the first things that this article dives into, and actually also which the other reading for this week also starts out with, is by thinking about the differences between public health ethics and medical ethics. And it does that because public health ethics is sort of a more recent field and phenomenon than medical ethics, which has a sort of longer history and is more familiar. And so it's natural that they sort of begin by thinking about how is public health ethics different from ethics in medicine. And those differences have to do in large measure with differences between public health and medicine themselves. So if you think of medicine involves patients typically willingly coming and seeking medical care, and presenting with a particular problem and then interacting with healthcare workers, such as, say, a medical doctor or a registered nurse, and receiving some kind of treatment for whatever their problem is. And there are many ethical issues that can arise in those kinds of settings, such as informed consent, for example, or the responsibility of the physician with regard to the patient, and so on. But public health is obviously very different than that. Rather than an individual relationship between, say, a medical doctor and a patient, you have populations, and then usually the most important actors in public health are often going to be governments. And governments enact policies, say a tax on sugar-sweetened beverages, and these policies impact a whole lot of people, many of whom never chose to be affected by this policy in the same way that someone who goes and seeks medical care chooses to be involved in healthcare. And this policy might affect them in ways that they don't like. It might cause them to change their behavior in ways that they would rather not do. And this can raise all sorts of different ethical issues in public health that are different from those that you would find in medical ethics. And so one of the key ideas for both of the readings for today is that since public health is so different than medicine, the ethical issues that arise are also different. And this is one of the things we'll talk about in the first week's class, is what are some examples of how these things differ. So that's something you can think about. So let's just dive into this a little bit more by thinking about what is public health. What's the definition of it? Now, of course, you're all getting a degree in public health, so you all have an idea about that, but here's just a well-known definition that could be helpful. So this one is cited in the Childress and colleagues paper, and it states that public health is what we as a society do to assure the conditions in which people can be healthy. So there's a few things to sort of take out from this definition. Public health involves collective action. So it isn't just an individual medical doctor and an individual patient. It's involving some collective action, usually by a government, although as we will see, it can also be other types of organizations that aren't government organizations can also be involved in public health. Moreover, there's a population health that's the aim rather than individual health. And finally, related to both of those prior points, determinants of health matter a lot. So it isn't just health care that's important for public health. It's things like how much education people have, where do people live, what's the work environment that people experience, what kind of air do people breathe, how do people go places, do they have to drive, do they walk, do they take public transportation, and so on. All of these things can have an impact on people's health. And so with public health, you're considering a much broader range of issues than one would normally be considering within medicine. Moreover, it's helpful to think about the publics in public health. And this is, I think, a really interesting point that the Childress and colleagues paper raises, is this distinction between different notions of public in public health. And they draw three different types: numerical, political, and communal. Now, the numerical public is essentially the population. So you think of population health, the numerical public is just like the population. Now, depending on what issue or topic you're concerned with, you might be focused on a larger or smaller population. Maybe you're thinking about the entire population of Canada, or perhaps the entire population of BC, Or you might be focused on a population like people who live with HIV. You could be focused on a number of different populations. But a population is always some collection of people. And these people may not know each other. They may never talk to each other. They could just be this sort of scattered, disorganized group of people. But they're a population about which you might have statistics and data and so on. That's distinguished from what Childress and colleagues call the political public. The political public is essentially the government or government agencies that are involved in public health. So federal, provincial governments are included, so municipal or city governments, but also things like BC Ministry of Health or the Health Canada and so on would all be involved in this sort of political public. Finally, and in some ways, the least obvious of these three categories of public is the communal. And the communal is essentially non-governmental organizations who engage in public health issues. And these are often going to be things like health advocacy groups, say like Diabetes Canada, or trade associations like, say, the Canadian Beverage Association. And if you think of an example like taxes on sugar-sweetened beverages, you can see that both of those groups are very likely to be involved in that issue, but most likely on opposite sides of the topic. And so the involvement of groups like this can often be a very important factor in public health ethics issues. All right, so let's think about when you're doing public health ethics, what are the kinds of issues, what are the kinds of topics that you're going to be thinking about? And this is what's in the reading referred to as these general moral considerations. The general moral considerations aren't quite principles just yet. And we'll get to more to things in a bit that look more like principles. But the general moral considerations are just sort of things you would think about if you're doing ethics in public health. And Childress and colleagues give a long list of these, and I've organized them into 4 categories to make them easier to remember. So beneficial consequences, justice, respecting individual rights, and trust. So beneficial consequences, essentially just what it sounds like. This is the idea that when you're doing public health, when you're designing a public health policy or intervention, the goal is almost always going to be to improve the population health. Maybe it's the entire population, maybe there's a particular subpopulation you're focused on, but there's some population whose health you want to improve. You want this population to have better health. And that's the beneficial consequence. And so what Childress and colleagues are really focused on and interested in their discussion is the potential for that goal, that is increasing the health of a population, for that to sometimes to create a conflict or perhaps a trade-off with other types of moral considerations. So justice and respecting individual rights or trust. So we think about the first here, the next one on the list here, justice. This would be, say, distributing benefits and burdens fairly, distributive justice, and ensuring public participation, including the participation of affected parties, procedural justice. We think, well, how could it be that beneficial consequences could conflict with that? Well, in fact, if you think about something like providing advice about, say, healthy diet. Now, suppose that people who are more educated are more likely to listen to and follow that advice about healthy diet. Or let's say recently we've heard a lot about the dangers of drinking alcohol, even in small quantities. People who are more educated might be more likely to heed that advice and therefore improve their health, say by drinking less alcohol. But people who are more educated probably already have better health than average. So by improving the health of the overall health of the population, you might actually increase the difference in health between people who are educated and people who have less education. So that could be an example where you've got an intervention that has a beneficial consequence in terms of the overall health of the population, but which actually results in greater inequality in health and perhaps arguably a greater injustice in terms of health distributions. It's easy also to think of examples where beneficial consequences of a public health intervention can conflict with individual rights. So if you think of a requirement to get vaccinated, or back during the COVID-19 pandemic, requirements to wear masks, clearly these requirements to wear masks had beneficial health consequences for the population, but they also restrict what individuals are free to do and not to do. Trust is another one there. It might be a little harder to find examples where beneficial consequences would conflict with trust, but this is also an important ethical consideration. Obviously, it's very important for public health institutions to maintain trust with individuals in the population. Otherwise, it's going to be very difficult to get folks to do things that health ministries would like them to do. All right, so let's then we're going to look at the framework that Childress and colleagues propose for public health ethics. And first, I'm going to say just a few words about the difference between a framework and a theory. So frameworks tend to be focused on a particular type of issue, like, say, public health ethics in this example, whereas theories tend to be more abstract and much more general. Theories also tend to focus on a particular way of looking at ethics. So, for example, utilitarianism says, what makes something right or wrong is that it brings about the best consequences overall. Well, frameworks tend to be more willing to just sort of pick and choose ideas from different sources and not be committed to one sort of theoretical outlook. So frameworks then tend to provide guidelines for how to make ethical decisions in a particular context, like public health. As we'll see, even within public health, you can find different frameworks for different sort of sub-issues in public health. So for instance, we'll look at a framework for environmental health later on. We'll also see a framework for white supremacism or combating white supremacism in public health and later in the term. So what's their framework then? So the framework that Childress and colleagues propose essentially has these 5 criteria. The first one is effectiveness. The idea is that if you're looking at some public health intervention, the first thing you want to ask is, will this thing actually improve the health of the population? Is there some evidence to think that this thing will actually produce some overall good consequences for population health? If there is no evidence like that, then probably you just should not proceed with this thing at all. You should just stop there and say, okay, there's no evidence this would do any good, so let's not even go any farther with that. Forget about it. It doesn't pass the first test here. But suppose you do have an intervention that there's some reason to think that it would improve the health of the population overall. And the next thing you want to ask is, well, okay, but does it have any other issues, any other ethical downsides? Like maybe would it increase inequalities? Would it sort of restrict freedom in some way? And then you want to ask yourself, well, if it does have some kind of downside like that, would that downside, how does that downside compare to the benefit? Does the benefit outweigh that downside? And you want to ensure that the answer to that is that yes, the benefit does outweigh. It is strong enough to justify incurring whatever this negative feature is. The next thing you want to ask in this approach is, well, is there any way we can try to minimize that downside, whatever that is? Suppose it's something about restricting freedom. And the next two are really about, is there some way we could do this intervention without restricting the freedom? Is it really necessary to restrict the freedom? Could we find a way to do it without that? And what's the way we could do this intervention that restricts freedom the least? That's the least infringement. And if we can, whatever would be the least restrictive way to do it, that's the way we should pursue. So finally, public justification is that it should be possible to justify all of this to the public. Whatever you're chosen to do, it should be possible to explain to the public and to rationally justify why this is the option that's being chosen. So here's an example to think about and that we can discuss in class. And this has to do with prenatal testing for HIV. As you probably know, prenatal HIV testing is effective for reducing risk of perinatal HIV, that is transmission from the pregnant person to the infant during birth. But not everyone who is pregnant gets tested for HIV. And here are two possible ways you could take to, or two possible approaches you could take to asking a pregnant person to be to get tested for HIV, like when they're seeing the doctor. You could say, okay, well, you could explain what the HIV test does, and you could ask their permission, say, okay, here's all the information about this test. Would you like to get tested? And this is, in BC, for example, this is pretty much the way it's done, the sort of informed consent. Another approach would be to say, well, there's lots of tests that are sort of routine, And you could just treat HIV as one of these routine tests that you just sort of automatically do when someone seeks care, and you don't actually sort of ask for their consent. Now, in this case, you might get a higher rate of HIV testing, but it seems like it would restrict the freedom a bit more. So something to think about is, how would that work out in Childress and colleagues framework? Would that be justifiable? That's something we can talk about in class. Goodbye.